All right. So this is getting into the viral diseases of the digestive system. So we finished up looking at two of them. We looked at rotavirus and norovirus on Tuesday. And so now we're getting the ones that you probably heard of before, hepatitis. And so hepatitis simply is just inflammation of the liver. Hepa is liver, itis is inflammation of. So here, hepatitis, inflammation of liver, and it's actually 5 unrelated diseases. Even though we call them A, B, C, D, and E, they're actually completely unrelated. And so we'll see how each of these work. But for most of them, it actually comes down to being jaundice is the first clinical sign, besides probably some pain. But the jaundice, or essentially the yellowing of the skin. Even in darker complected individuals, we can see that yellowing in the white of the eyes. And so that's a telltale sign that there's something going on with the liver. And so people that have jaundice, can be manifested by lots of things, alcoholism, other types of viruses, but a lot of times it's going to be the hepatitis viruses that we're going to look at here in the next few slides. So the first one, hepatitis A, this is actually a foodborne virus. It's going to be an acute illness. So when we call it acute, we're talking about it being something that you recover from. It's not something that you carry for life. So hepatitis A is something you contract. And usually for most people that are healthy, they're going to clear it. For people that have immunodeficiencies, it can be potentially worse, but for the most part, it's going to be something that's cleared pretty easily. Most people are not even going to notice that they have any signs, but some are going to end up having signs such as jaundice, fever, fatigue, clay-colored feces. So this is going to be from the problems in the liver where the toxins aren't being removed completely, so it shows up in the fecal matter too. And vomiting, but this is going to be after about a month of having the virus. So again, makes it difficult to trace back where it may have been accumulated from or where they received it from. So it's hepatitis A virus. It's a RNA virus, picornavirus family. I just put these up here, not that I asked you questions, but so that way you see redundancy. Some of these viruses are part of the same families, but actually manifest as different diseases in different parts of the body. Pathogenesis, it reaches the liver by an unknown route and ultimately replicates into the bile and eliminated into the feces, which is why it's a digestive disease. The fecal oral, mainly contaminated hands, food, and water. So this is one that you can contract from eating raw foods if they haven't been handled properly. So this can be things like shellfish, such as oysters. It can also be from just bad techniques in the kitchen. But most outbreaks are going to be traced back to restaurants where the food handlers failed something. They failed some sort of ultimate keeping things clean. High-risk groups are going to be children in daycare centers, residents in nursing homes, international travelers, and sexual contact with somebody that has hepatitis A can be transferred that way too. It's not just fecal oral. Incubation period is about 30 days, as we already pointed out, and it can spread pretty quickly because the very first patient 0 for an outbreak won't know that they have it until 30 days later, and they're passing it on to everybody else. So it can flare up pretty quickly when we have these outbreaks. So treatment, there's no treatment available per se. We do have a vaccine, though, that was introduced in the 90s. That's pretty effective. It's a 2-dose vaccine. You can usually get one and then a 6-month or 1-year booster. I can go back and look. But ultimately, once that happened, we see that there's a huge decrease in the number of hepatitis A cases that we see around. Occasionally, we get them flaring up here, usually from tainted oysters, but never anything that's so concerning that would stop anybody from eating them. It's just something to be aware of. Hepatitis B is much more serious. It's more of a chronic disease. This one, however, can be everything from asymptomatic to severe. So some people get Hep B, don't know they have it either. They can actually clear it. So it's not that you get the virus and you're automatically going to be sick and get hepatitis B signs and symptoms. Some people can clear it without it actually manifesting. Incubation period for this one's even longer. It can take upwards to a quarter of a year or better to ultimately start manifesting symptoms. The very first symptoms are going to be acute. It's usually going to be cleared within a few weeks. You're usually rarely going to be fatal when it's actually an acute disease. However, for about 1/5 of everybody that gets the acute version of hepatitis B, it's going to move off to be chronic. And this is where we actually talk about people that have hepatitis B. This is what we're actually referring to when we're worried about patients that have Hep B. It's the chronic ones. They actually carry for the rest of their life sometimes. So this is going to be 1 in 5 develop cirrhosis. Cirrhosis is where the liver is one of the only organs besides the skin that actually can regenerate itself. And so when it actually has cirrhosis, that means the scarring is so bad that it isn't able to function, nor is it able to regenerate those portions of the liver. So as cirrhosis continues to spread throughout the liver shuts down completely. Those people either A, are going to die or B, needing a transplant. So ultimately, that's what's saying here, develop cirrhosis, then that leads to liver failure. Liver failure can start leading also to liver cancers. That cirrhosis, all that damaged cells can eventually cause cancers to manifest. And we get about 2,000 to 4,000 cases per year of fatalities based off of hepatitis B here in the United States. It's a double-stranded DNA virus, so RNA virus for Hep A, DNA virus for Hep B. So again, just to point out that they are not related whatsoever. They're in completely different families. The only thing that's related, the only thing that makes them related is that they all manifest in the hepatitis type diseases. So this is a picture of what it looks like. Again, nothing here that you need to necessarily worry about, but for those of you that are interested in what the shapes and what the virus actually looks like, these are some pictures to show that to you. The pathogenesis, just like every other virus, it has to attach. So it's going to infect only the liver cells, just like HIV only infects the CD4 T cells for the most part. Hepatitis B infects the liver cells, so it's going to have to attach to a liver cell. It's got an envelope around it, so go back and look at chapter 13 if you don't remember your viruses, and it gets basically uncoated and goes into the nucleus, essentially starts replicating its DNA, and once that happens, it's going to start making new virus, pops out, starts spreading, destroys that liver cell as it starts spreading throughout the liver, continuing that damage along the way. Epidemiology, this one's transmitted by body fluids. So if you're going to work in allied health fields, this is a mandatory vaccine for the most part nowadays. It's only been in the last few years that they've mandated at pretty much every hospital I can think of. And so as part of your ability to keep your job, you have to get this vaccine, and then you have to get a booster once a year, I believe. So this one's transmitted body fluids. That's why it's required. Any body fluid can have hepatitis B virus in it for somebody that's infected. So saliva, blood, semen, all these, any factors that lead to somebody being exposed to these body fluids are going to leave you potentially at risk. So therefore, the vaccine is essential. Other things that are going to be at risk is sharing needles. So again, intravenous drug users, toothbrushes, anything that touches body fluid and then somebody else is sharing that has the potential to pick it up. But one of the things I did point out was back here is that the virions can be infectious a week outside the body, which is pretty odd for a virus. A lot of times viruses are dead the second that they leave the body or within a few seconds. This one's actually stays infectious for up to a week. And so things like these, toothbrushes, razors, towels, all these things that are shared, even if it's been a day or two and you pick it up and use it, it can still potentially have infectious virions on it. So about half of new cases, though, in the United States comes from unprotected sex, essentially body fluids from somebody infected to somebody that's non-infected. So we get about half of them from that. Chronic infections, they circulate in the blood for years, and this is going to be something that they just carry. They may have flare-ups eventually once the liver has lost that battle, again, being like a strategy game that we talked about with the immune system for the entire semester. Eventually, the liver just runs out of cells that it can replace faster than the virus is wiping them out. So then as the people that have chronic cases of hepatitis B, they're going to eventually keep moving towards liver failure and potentially death. Failure to clear is age-related, so people that get it younger in life, they may only get the acute version of hepatitis B. Ones that are older, their immune system's weaning a little bit, it may lead more to the chronic infectious portion. So we get about 45,000 new cases of hepatitis B a year in the United States, so it is prevalent, but not something that's out there, to be fearful of, but just to be aware 1 million are infected chronically in the United States. Remember, the United States is about 350 million, so 1 out of 350 people has hepatitis B. And 2 billion have been infected globally. That's a much higher proportion globally than it is just in the United States, right? Because there's roughly 7 billion people on Earth, so 2 out of every 7 has it worldwide. 1 out of every 350 have it in the United States. So it's a much more prevalent disease outside of the United States, which is why one of the risk factors was international travelers. International travelers are going to be much more at risk because they're just going in areas where it's more prevalent. And so you just have to be more mindful. So this is what we also call the silent disease because it is in the top 10 causes of death worldwide. It's silent because most people don't know they have it until it's late. It's not like it's something that makes big headline news. And so it gets this nickname of the silent disease.
How does that end up killing you? What is it that usually?
Liver failure. And if you can't get a liver transplant, usually they won't give you a transplant if you have hepatitis B, because that just means the new liver is going to get infected also. So it's one of the negating factors to a liver transplant. All right, no curative antivirals as of yet. Of course, we're always working on these things to try to find ways to clear these different viruses that currently we don't have treatment for. So some of the new treatments are similar to the same treatments we give to HIV patients. It's going to be the reverse transcriptase inhibitors, interferon injections. Remember, interferon is a natural chemokine that's released by the immune system to stop viruses. But now that we know that that's what they do, we can actually give it intravenously. So both of these have been very helpful in prolonging life and quality of life for people that have hepatitis B chronic infections. We have a vaccine since the 80s, which is the go-to. Again, there's, I think that series, you can get it in a series of 3 or 4. 4 is if you're trying to get it done within like a month or so. They do it like once a week. And if you have time, then they do 3 over a series of like 2 months. So you have these vaccines, and then there's a booster that's required usually once a year or so. But they can check your titer levels in your blood and determine if that vaccine is needed or not. Then we have an updated vaccine that is now a subunit vaccine. A subunit vaccine is one that has no live virions in it. So this is perfectly safe for everybody to use. There's no chance of actually contracting hepatitis B when you're using a subunit vaccine. This is just saying that there's a combined vaccine schedule for A and B, so that way the immune system's not getting overrun. So we actually have schedules built out for all these to ensure that everybody gets vaccinated from childhood. Nowadays, it's just catching all the adults up. Vaccination may prevent upwards to 1 million new cases a year. So this is something that's a big deal for us to make sure we get out there. All right, hepatitis C is the last of the 3. That's something you probably heard of. Most people have never heard of DME. But C has been made famous by a couple celebrities that have come up with. Pamela Anderson, I know, has Hep C, as well as a couple musicians. And so they've made it a big priority of their life to, advocacy for this disease. So it's actually got into the headlines a little bit more. It's similar to A and B. Again, it's a hepatitis, so it's going to cause liver disease. But it's not as well known because it's not as prevalent. So 65% of individuals who get hepatitis C have no symptoms whatsoever. Again, they clear it. Their immune system won in the very beginning, clear it out. They never even had it. 25% are going to lead, only about 1 in 4 are going to lead to that jaundice phase where there's something clearly wrong. They have that yellowing. That's what's usually going to send them to the doctor. Out of those 25%, 80% will develop into a chronic infection. And so that's going to be the ones that actually need to get treatment, need to get some help. So again, this one's back to an RNA virus, but instead of being a coronavirus like Hep A, this one's a flavivirus. So yet again, just pointing out, not that you need to know those things per se, but it's just pointing out that all these viruses are not related, the hepatitis ones. So this one, we only were able to start cultivating in the lab about 10 years ago. And so because of that, again, we're just really starting to understand that it's a completely different virus than A and B. And because of that, there's very few details known besides that we know you can contract it from blood, probably other body fluids too, but the one that we recognize the most is usually blood. This one's also got a long incubation time, just like A and B. It can take upwards to months, if not a half a year better, to ultimately start showing those signs of jaundice. So epidemiology, most common chronic blood infection in the United States. Over 3 million new people infected a year now that we recognize that it is a new virus. Before it would just be thinking that they had Hep B or Hep A. Now that we know it's C and we're able to do diagnostics and recognize it, we're now getting some numbers that are much higher than we ever anticipated. But again, we didn't recognize it was a different virus. 20,000 new cases a year. We only discovered it after post-transfusion hepatitis continued to pop up after HPV was excluded. So what does that mean? Back in the 80s, we didn't test the blood. If somebody donated blood, we'd only test it for what blood type it was. We didn't recognize that people could actually have viruses in their blood. And so there was a major problem in the 80s with people getting blood transfusions and contracting HIV or HPV or hepatitis B. And so they realized that this was a major public health issue. And they started testing the blood. And if it was positive for either of those diseases, along with a long list of diseases, it gets excluded. Well, we didn't know hepatitis C existed. And so when we made sure that the HPV wasn't in there and we gave the blood to somebody, a recipient, they contracted hepatitis, right? Well, where's that coming from? And that's where we're ultimately able to recognize it was caused by a different virus, this Hep C. So once we recognize that post-transfusion, hepatitis cases fell down to basically zero because we recognized that there was a third virus. And the other ways that mechanisms of exposure are not always obvious. Pamela Anderson, I think she got hers from tattoos, if I remember correctly. So it was ultimately using a needle that was basically shared, tattooing needle. And body piercing also can be problems. Again, all this stuff's tested now. You get clean needles, clean all autoclaved or single-use needles nowadays, but back in the 80s, 90s, and early 2000s, that wasn't the case. It was usually a needle that just maybe cleaned briefly with some alcohol, and that may not be enough to actually clean the virus off.
So did more people contract HIV through not being tested, or was it more through?
Sexual intercourse would be a bigger one, but blood transfusion was a significant number of people, especially in the 80s. Was a major problem, but it was sexual transmission was probably more prevalent.
I think the hepatitis is treatable.
They are. This one's treatable. A is treatable, to the point where it's an acute disease. But most of them are going to be prevented by vaccination first. This one's no cure, but actually this slide needs updated because this came out from the drug for Hep C. So it's something that again. Sometimes the textbook's a little behind, modern day information, but Hep C actually has a new drug out there for it. So again, epidemiology, anything that you can share, blood fluid, bodily fluids is going to cause you to potentially be exposed to it. So the same thing as what we've seen in the other ones. Blood transfusions, as we just pointed out, are extremely low now because we test all that. No cure, but yet again, we have the same mechanisms that we use for the other viruses, chronic viruses such as interferon treatments, is key. And as I just pointed out, I know that there's a new Hep C drug that was just released. No vaccine, but actually having a vaccine against A and B can help you prevent having you get dual infection, which is going to be key to hepatitis D, the next slide. Having those protections against A and B, at least you don't have to worry about contracting them too. A lot of times we get people that have dual infections or triad infections, which then just exacerbates their problems. So here's all five of them together. Again, I leave D and E separated out here just because they're not ones that we see as often. A, B, and C are the ones that we tend to see more often in the clinics when people come in with jaundice. So I'll go through D and E real quick just because they're only shown here. But D is known as what we call a satellite virus. It can't actually cause disease on its own. So hepatitis B, we never really recognized it existed. But what we did notice was that people with hepatitis B, they had different timelines to how fast they actually contracted, how fast they died. I guess is the right answer, right? So some of them would go on for years, others would perish pretty quickly. So there was a question: how was that happening? And so as we continued testing and getting our diagnostics better, hepatitis B was recognized as a defective virus. It can't survive on its own, but with B, it exasperates the breakdown of the liver. And so we now can test for D in people that have hepatitis B to help understand what the progression of their disease may be. If they have hepatitis B on their own, it's not as bad as having dual infection with B and D. E is a fecal oral virus, also causes a little bit of problems like A, but it's really only related, it's only typically dangerous in pregnant women because, again, viruses are much better at crossing over to placenta. So E is not something that we really hear all that much about because it's very minor, very selective in the type of patients that tend to have problems with it. But again, it's another foodborne fecal oral disease.
So then if, like, would that cause most likely like death in the
Infant?
Yeah.
That usually causes miscarriages. All right, so now we're switching over to the last few slides here. Again, I don't ask a lot of questions on the eukaryotes, but there are a couple of eukaryotes here that are important for the digestive diseases. One is Giardia or Giardiasis. This is a protozoa, and so these are the single-celled eukaryotes. This is a fecal oral, but mainly from contaminated water. And so this is something that you get from somebody maybe drinking water out of a stream, typically going to be travelers, or say like you're hiking in a mountainous area, whatever, you just getting water in the stream may look like it's nice and clean, but reality is these protozoas are everywhere. And so this is usually where we get it. 2/3 of them are going to have symptoms within about 2 weeks or so. Symptoms are usually mild, a lot of gas, nausea, some cramping, maybe some, well, as the book says, explosive diarrhea, fatigue, and a little bit of weight loss, but it's rarely ever going to be fatal. It's just something that's very inconvenient at the time. It usually is going to take a couple weeks for it to clear. If without treatment, with treatment, we clear it much faster. But some cases become chronic. Those people are the ones that just allow it to continue to manifest for periods of time without going and getting treatment. Anybody who goes and gets treatment, most of the time are going to be just fine. Both symptomatic and asymptomatic can become long-term carriers. So even after you've healed up, you may still be releasing the cyst. And so when we use the word cyst here, we're talking about the little hardened shells, just like endospores for bacteria. For eukaryotes, they form these cysts, and they're basically like a hard shell that they can survive in for long periods of time until they find the right, the right living conditions to pop out of them. So for people that actually get Giardia, they can become long-term carriers for months, if not years, even after they've cleared it. The causative agent, Giardia lamblia, it's a protozoa. There's two forms. You have the trophozoite, which is the actual infectious portion, and the cyst, which is the hardened, dormant portion. So it's got two parts of its life cycle. Same stuff we just talked about. Nothing exciting here. Nothing I'd ask questions about unless you're interested in the pathogenesis of actually causing disease. But pretty straightforward. The cyst is what you usually are ingesting, gets into the stomach acid, is able to survive the stomach acid that is in that cyst, gets into the intestines, and ultimately frees itself into the trophozoite and starts causing the problems in the intestine. Epidemiology, pretty low because the cyst is just a hardened shell. So you only need a couple of them to ultimately cause disease. All they had to do is pass through the stomach acid, and they open up on the other side and they're free to clear. So it doesn't take much. So that's why seeing people that are just taking a little drink out of the stream can be enough to infect themselves. So hikers, person-to-person transmission is going to be daycares where the child may have it. They're cleaning diapers and whatnot. They're exposed. You know, those cysts are coming out in the fecal matter. You know, the daycare workers are cleaning up the kids all day long, and they can spread it throughout the daycare pretty quickly. Any sort of oral anal contact can transmit it. Transmission by contaminated food. You know, again, food workers, food handlers. And here, just a single human stool can carry 300 million cysts in it from somebody that's infected. So this is pretty serious for it to spread pretty quickly when you only need to have 10 to infect a new person. And a single stool can have over 300 million in it. Treatment, like I said, there's treatment out there. These are all standard treatments that we use for most protozoas. So there's those particular three medicines are pretty much the standard for any protozoa. Municipal chlorination does not destroy the cyst. So if it does get into the water systems for a municipality, chlorine is not enough that can do it. So the water has to be filtered also. The only way to pull the Giardia out is filters. And so you see a lot of these water bottles out there now, especially now they're becoming more common. Originally, they were just made for like survivalists, you know, people that like to go out and camp on their own, backpacking and whatnot. But the water bottles themselves have a filter system on them, right? And that filter's in there mainly to block Giardia cysts because they are such a prevalent problem in water. Water purifying tablets are also not very reliable because, again, you know, you're not having success in breaking that cyst. The cyst is a really hard shell. And so we have to break that cyst open. So the only way you can do it without using filters is boiling the water for upwards to a couple minutes. That heat penetrates the cyst, breaks it open, and kills it. So that's about the only thing you can do to stop that. All right, cryptosporidiosis is a disease that also we tend not to see very often, but it is in people that are immunocompromised. So this one's going to be fever, loss of appetite, nausea. Again, we're in the digestive diseases, so that makes sense. Cryptosporidium parvum is the causative agent. It has two different life cycles also. It has the oocyte, which is the oocyst, which is the sphere that has the 4 sporozytes in it. So sporozytes are the live version. The oocysts are essentially the hardened version.
Is it oocyst and what?
Oocysts and the sporozytes. So it's got two different life cycles too. So once you get into the small intestines, it releases those sporozytes, just like Giardia. You know, Giardia release theirs once they got past the stomach acid. Same thing's happening here. Once it gets through the stomach acids, those oocysts are able to survive the stomach acid, get across the other side, releases the live version or infectious version, and it's able to infect the epithelial cells of the intestinal wall and ultimately multiply inside them. And just like a virus, when it breaks open those epithelial cells, it destroys those cells, causing all kinds of damage to the intestinal layer. So yet again, because it has a cyst, it only needs a few of them, and you can spread person to person through fecal oral. This is common cause of traveler's diarrhea. So if you travel and you have loose stool for like the first day or so, that's usually what we call traveler's diarrhea. It can be caused by this cryptosporidiosis. Resistant to chlorine can survive up to 6 months in food and water because of that cyst. So yet again, it's just problematic because it's everywhere. You only need a few of them. And once you get them, you know, they break open, make you sick for a couple of days, and then you clear it. Again, nothing here particularly that's going to be fatal. It's just annoying more than anything. Resistant to chlorine, too small for some filtration methods, so this requires another level of filtration. Much smaller filters, you know, getting the filter holes to be even smaller than what's normal or what's accepted as being standard. That sometimes these cysts can actually make it through, so you have to use even specialized filters. Found in a lot of different animals. So again, working in any sort of livestock, working in like a kennel situation, anywhere where you're dealing with large cohorts of dogs, cats, or livestock, you could potentially be exposed to this disease too. So again, same exact medicine as we've seen for Giardia is used here too. And sanitary disposal of fecal matter, of course, is always, these are almost like, if everybody did this, we wouldn't have diseases, but, these are where breakdowns happen is when the sanitary disposal is not happening or there's mistakes made. Treating the water with filtration, UV light, UV can break through the cyst and break them open, as well as ozone can break it open too. So there's actually ozone filtration systems out there. These are being used in the larger sewer and water treatment facilities. It's usually not something you buy for your home use. Pasteurizing your liquids. Remember, pasteurizing is just using high heat. So using that high heat will basically break those cysts also. And washing your hands is always a good thing. All right, the last one here is pretty much the same idea. It's the same system as the one we just looked at, but it's a little bit larger and it's not infectious in the fecal matter. So it's got a different name, cyclosporosis. But the same signs and symptoms, it's just not as prevalent because the oocysts are not as infectious or not as easy to spread. So therefore, we don't really know a lot about it. The only way we can really truly recognize if somebody has it is a small intestinal biopsies. And that's really not something we're going to go into for something that is easy to clear. So it's something that we've learned post-mortem or because we were in there for other reasons, we're able to recognize that. So no person-to-person transmission. Maturation of the oocytes are going to be in warm, moist conditions. One of the things that we have recognized and why we talk about it in here, even though we don't know much about it and it's hard to diagnose, is that it has shown up as epidemics with raspberries. Strangely enough, it's just one of these odd little factoids out there that we have seen epidemics break out from infected raspberries, and that spreads around. And we see a whole bunch of people come into the clinic with similar diarrheal diseases, and we can link it back to raspberries. Right? So this just happens to be what we've seen. Same medication as we use for the other ones, and ultimately there's no specific preventative measures besides boiling or filtering your water, and that's about all we can do for it.
Is there something specific about the raspberries, or is it?
They got it infected somehow from the water, whatever water they had. Last one here is your amoebas, right? So this is going to be something that we have seen here in southern Louisiana, as we talked about before. I know that St. James, St. Bernard have both had cases. And so this is caused by an amoeba called Entamoeba histolytica. So this is one that's been making the news every so often. This one causes acute dysentery. Remember dysentery is when you have blood in the diarrhea. So this is when it's become very serious. Can be fatal, and where it's been fatal in the case, I believe it was St. James Parish, that was where they were actually using a slip and slide, and they were sliding on the slip and slide, and they got water up their nose, and that allowed the amoeba to have direct access to the brain and got inside the brain and killed them. If you take it the normal way as a digestive disease and you drink it, usually your stomach acids are going to destroy it. Right, so it's nothing that we have to necessarily worry about getting through natural route. It's that random, weird getting water up your nose type of situation that could potentially make it fatal. So pathogenesis, the cysts survive just like the last three we looked at. None of these are different. All three of these are basically the same. They have a hardened cyst, survives the stomach acid, gets on the other side, opens up, and starts to feed on whatever's in there, whether it be your intestinal cells, or in this case, it's feeding on the normal microbiota bacteria once it gets in there. And that's going to cause cramping and diarrhea because you're messing with the normal microbiota. And then ultimately can potentially get into the bloodstream, becoming systemic, getting into other parts of the body, starting to cause damage. And that will ultimately cause death, right? But as long as it stays in the intestines, usually it's going to be pretty minor, but for those that get dysentery, it's because it's destroyed the intestines so much that we're getting ulcers in the intestinal lining, because chewing through the intestines so much is opening up holes that brings the blood into the intestinal wall, then that manifests into dysentery. So it can be problematic. We give it a special name, amoebic dysentery when it's actually caused by enterolytica. The epidemiology is pretty mild, but we get about 3,000 deaths per year, worldwide. Low infectious dose because it still has those cysts. So all 4 of these eukaryotic diseases all have cysts, therefore they all have low infectious dose. U.S. mainly going to be in poverty-stricken areas. Farm workers, homosexual sex is going to be also problematic. Again, moving those cysts where they're not getting beat up by the stomach acid, sometimes exposing them right to the intestines that are allowing them even lower doses. Humans are the only imported reservoir, but that doesn't mean we don't see it in other types of animals. But this is the only reservoir that actually, we see it, where it's problematic is going to be human to human. Again, the same exact medicines as we use for the other 3. And sanitary measures are always going to prevent it. Where we have problems with the parish, this is what we talked about on Tuesday, is chlorination of the water systems, not treating your water properly. So that's the end of chapter 24. I'm going to end that one, and then we'll start up chapter 27 so we can keep moving. I want to try to make sure